States Medicare 2019 and other policy changes for telehealth. This webinar is being produced and hosted by the National Consortium of Telehealth Resource Centers. The Telehealth Resource Centers are 14 resource centers that work collaboratively together to provide technical assistance to people who have questions regarding telehealth, from how to start a telehealth program, to policy questions, to questions on technology. There are 12 regional resource centers who cover specific states, and 2 national resource centers, one covering technology and one covering policy. A few disclaimers and housekeeping items before we start our webinar today. Any information we provide today should not be considered legal advice. It is strictly for informational purposes. If you are seeking a legal opinion, we suggest that you seek out legal counsel. Also, if either Jonathan or I happen to mention a company or show a project, please know that neither one of us have any affiliation or financial arrangement with such a company. This webinar is being recorded and will be posted later after the webinar for those who may not be able to attend or wish to listen to it again. If you have questions, there will be a Q&A section after the presentation. Please place your question into the chat box and we'll address them as they come in. So a little bit of information on what CCHP at least does is that we track all of the telehealth state policies, Medicaid policies, regulations, and laws. That is a snapshot of our interactive map where that information is stored. So if you're interested in a particular state, you can click on that, it'll bring up the information. We also track any pending legislation on the federal and state level, which can also access through the map as well. The information regarding the laws, Medicaid policies, and regulations are updated twice a year in the spring and the fall, but the legislation tracking is more frequently updated as those bills go through the process. Today we'll be talking about the recent changes that have been enacted by Medicare related to telehealth or internet-connected technology. A little bit of background, Medicare telehealth policy reaches back all the way to the late 1990s. That's when Medicare began to reimburse for telehealth delivered services. And policy since around that time when it was first enacted has not really changed too much in regards to the telehealth side of things. There have been some small statutory changes here and there, but really not a lot of statutory changes because that would require passage of a bill through Congress and signing by the president. The last major change was probably back in 2008 when they added skilled nursing facilities as an eligible regional site. However, there have been a series of administrative changes that CMS was able to do underneath their powers to telehealth and how Medicare addresses telehealth services or how they address technology delivered services. Probably many of you are aware of this, but just sort of a high level background on what Medicare is doing with telehealth. Generally, the policy is that they will only reimburse for live video unless you're in a demonstration pilot in Alaska or Hawaii, then you get to use Store 4 to get reimbursed for that. There's a very specific list of providers who are eligible to receive reimbursement if they deliver services via telehealth. And one of the most restrictive policies is that it's very limited in where it can take place, and that is limited to a rural health professional storage area, a non-metropolitan statistical area, or a telehealth demonstration project. And that can be very limiting for certain states. I am based in California, and because of this restriction on where telehealth could take place for Medicare, about 98% of California is ineligible to be an originating site. There's also a limitation on the types of facilities where telehealth can take place, where the patient can be located. One of the more restrictive sites that is missing from the list that are eligible is the home. But we will get to that in a little bit later with some of the recent changes that have taken place. And also, there's a limited list of reimbursable services in that CMS, what they do for reimbursement for telehealth Medicare is that they do go by specific CPT codes. So as I mentioned, one of the most limiting factors on usage of telehealth in Medicare and reimbursement for it is the originating site, and that the patient needs to be located in a specific geographical and site type location. However, that has actually changed a little bit. It's opened up a little bit this past year. you had asked me maybe about 2 or 3 years ago what have been some of the advancements that Medicare has made with telehealth. I would have said that there hasn't really been a lot in addressing those restrictions because those restrictions are in federal law. So it would take Congress to change that and then the president to sign bill. But last year, they did do a couple of changes. It was not in a telehealth bill, a bill that was strictly addressing like the telehealth changes. It was in a larger bill. It was in the Balanced Bipartisan Budget Act. But what they did in that act was they took pieces from telehealth legislation that existed out there, specific pieces, and dropped them into the Budget Act. And one of those things was addressing the originating sites. However, it was not a sweeping change on changing some of those limitations for the geography and the specific site. What they did it for were for specific types of condition, and that was for end-stage renal disease. So what they did for end-stage renal disease is that they eliminated the rural restriction, so it does not need to take place in a rural area. If the service is provided in a hospital-based or critical access hospital-based renal dialysis center, or if there's a renal dialysis facility, or in the home. So they also opened up the location of where these services can be received to the home as well. They also did that for acute stroke. Now, for acute stroke, they eliminated the geographical restriction if a patient was receiving acute stroke services. So that opened it up for other locations such as hospitals, fairly qualified health centers who are located in urban areas, and allowing them to also treat those patients with acute stroke via telehealth and get reimbursed for it. The one thing though for these opening up of these new locations and eliminating the geographical restriction or allowing the home to be originating site, they were saying though, but you do not get the facility fee. So we're opening this up, you don't get the facility fee, and we're only opening up these locations if it's for end-stage renal disease and acute stroke services. So a little bit of loosening and relaxing of some of those limitations related to telehealth, but for very specific conditions. So other things that they have done starting beginning of this year that CMS has done is added additional services that they will reimburse if delivered via telehealth. Now, this is something that typically happens with CMS, and it is within their powers to do. So every year, CMS is allowed to add additional codes for reimbursement if the service is delivered through telehealth. And they do it one or two ways. They call them a category 1 way or a category 2 way. So it's basically their measure of seeing if the service should be reimbursed and provided via telehealth. Category 1 way is they look at the code and they see if it's similar to something that they're already reimbursing if delivered via telehealth. So, and that's typically how those codes get approved for reimbursement. And that's usually CMS saying that, these are the codes that we should reimburse. Category 2 is they do allow the public to submit codes for suggesting that they be reimbursed if delivered via telehealth. And when the public submits those codes, they're supposed to provide evidence that the provision of the services via telehealth is as good as it would be in person. Now, that's sort of a high standard to meet because there's actually never been explicit statement on what exactly would be sufficient evidence for that. So that usually is a little harder to try to get a code approved for via category 2, which is why we see a lot more times any new codes that are approved for reimbursement are category 2. So for this year, beginning at the January 1st of this year, 2 new codes are being reimbursed, and that's the G0513 and 0514, prolonged preventive services beyond the typical services of primary procedure. So those are now available for people to provide via telehealth and get reimbursed on. And I think I will now turn it over to Jonathan. So I will stop sharing. And Jonathan, do you want to go ahead and share your screen?
Oh, May, go ahead and keep sharing. I'll just ask for, I'll request control. Okay. Now I can request control and then.
I think you might have control right now, Jonathan.
All right, so now we need to resume the slideshow. All right. So before I dive into chronic care management, I just have to say, since Mei's a lawyer, she always makes this disclaimer at the beginning that she's not giving legal advice, and it got me thinking I should probably, since I'm a clinical psychologist, I should probably make a similar disclaimer. If you don't feel any better after listening to this webinar, I'm really sorry, but this isn't therapy. So we'll take it from there. Chronic care management. This is a set of codes that started last year and were extended this year, and this is a really exciting set of developments, because what Medicare is doing, what CMS is doing, is starting, because there's this huge statutory limitation that they can only provide. Medicare can only pay for telehealth services from certain originating sites. There have to be bills passed, laws enacted. Oops, I think you just changed. You took. I think you still have your mouse still works, Mei, even though I have control also. So if you can just resume the presentation. So there have to be bills enacted in order to change that rural restriction. So what CMS has done with these chronic care management codes and a number of other things that we'll talk about here in a minute is that they have defined new types of connected care, technology-enabled care that they're going to pay for, but they're not categorizing them as telemedicine per se. And so they don't fall under that same set of restrictive geographic limitations that standard in-person live video telemedicine care does. So chronic care management is one of those types of services. It's not categorized as telehealth by CMS, but rather it is a set of clinical services that one can use electronic means to provide, to enable, and get paid just as regardless of the use of connective technologies there. So the codes that were recently added. Last year there were some chronic care management codes added, and we won't go into specifically those. This year, Medicare took another step and added specifically remote physiological monitoring codes. So some specific codes for remote monitoring that allow for a setup. So an initial session when you're training or you're teaching a patient how to use things and setting up equipment, and then for a month of monitoring, the 99454 code to monitor for a month, and then the 99457 code for follow-up interaction with the patient around the results of the monitoring. And so a whole series of codes that one can use to implement a remote monitoring program. Okay, so now in addition, there are some other technology-based services that are new services, and these are also sort of very exciting on the one hand in that they're sort of brand new things that Medicare is paying for, but a little disappointing on the other hand in that they are the reimbursement is fairly low. So you get a little bit of good and a little bit of not so good. But I'll talk a little bit more about each of these. The brief communication technology, technology-based service or virtual check-in. People are just calling it virtual check-in. The remote evaluation of pre-recorded patient information. This is a sort of patient-initiated store and forward service, and then interprofessional internet consultation. So the virtual check-in is a service in which a patient can have an encounter using any kind of technology. It could be live video. It could be telephone. I don't know that other specific systems are specifically mentioned, but there certainly would be other ways to check in as well. But it involves about 5 to 10 minutes directly with the clinician. So this is not team-based care, but 5 to 10 minute interaction. Probably most of the time it's going to be over the telephone. And the idea here is that it replaces an encounter. So it can't lead directly to an encounter. In other words, if the phone call leads to a person, the doctor saying, okay, you really need to come in, that sounds pretty serious, then the assumption is the doctor is going to get paid for that encounter, and so the phone call itself is not paid for. Likewise, if the patient has been seen in the last 7 days, then the phone call is not paid for. In a sense, it's a follow-up to the previous encounter. So that's why those limitations are in place, and it's only for established patients. And there also needs to be verbal consent because patients are going to be charged a copay or co-insurance for this. So Medicare is just very clear that they don't want this service abused, and so patients need to be aware that they are incurring charges as they're doing this. Now, the remote evaluation of pre-recorded patient information. Imagine this primarily as a patient taking a picture of a rash or a lesion or something they're concerned about and sending that into the doctor to be evaluated, and then the doctor taking a look and getting back to the patient verbally within 24 hours. And again, as long as this is an independent service that isn't a follow-up to something that happened in the last 7 days or doesn't lead to an encounter in the next 24 hours, then it can be paid for independently. These patients have to be established patients, so you can't use this remote monitoring or this pre-recorded patient information stored forward to establish a relationship with a physician. And they don't have a specific consent requirement, the assumption being that if the patient is going to present information to the doctor, that they have, by that presentation, consented to the service. The interprofessional internet consultation is another sort of domain that has several different aspects, a lot of variation here in how long and how complicated and how extensive these consultations are. But these are consultations between providers where one provider can contact the other, refer a case, and that other provider might provide some sort of interactive discussion and review. So that's that first set of codes, 99446 to 449. That's the length and complexity of that discussion and review determines which code there, and it's going to be some sort of assessment and management services provided by a consultative physician. Now, those other two, the 451 and 452, allow for an electronic health record assessment. So this would be a situation where a provider requests a consultation, and it really just involves record review or lab reviews or other reviews of information that the provider has. And those can be 5 minutes or more for the base code, and then additional 30 minutes of consultative work, examining the record and making recommendations and whatnot. Verbal consent, again, is required because these are chargeable services, and any cost sharing needs to be disclosed. And again, you can use phone or internet, a wide range of telecommunications technologies to enable this, and they don't fall under that rural restriction that all other CMS telemedicine or Medicare telemedicine services do. Another set of changes, pretty big changes that happened this year, have to do with opioids, opioid treatment and substance use treatment generally. Because the Support Act was passed, and again, as we said, for specific rural requirements, geographic requirements, and other things to change in Medicare's telehealth regulations, there needs to be statutory change. And so because this is one of the few times that Medicare payment guidelines have actually been passed through the statutory process, they were able to remove the originating site geographic requirement for telehealth services provided for opioid use disorder or substance use disorder. Home was also made an eligible originating site, which it is not in normal telemedicine, normal telehealth Medicare telemedicine coverage. So for purposes of stroke and end-stage renal disease, as Mei pointed out, and now also in terms of for uses in opioid use disorder and substance use disorder, the home is a valid originating site, and originating site geographic requirements have been waived. So so these are some pretty significant changes that Medicare is implementing, and sort of along the lines of a lot of the experimental changes, or at least changes that they've implemented that they really want to know if these are working. So so included in this in the Support Act is the idea that within 5 years, CMS will take a good hard look at the results of these changes and see what sort of an impact it's had on treatment and on utilization. Other SUD and opioid-related policies have been changed as well. CMS is providing some more elaborate guidance to Medicaid, state Medicaid group payers. As you know, Medicaid is managed or regulated at the state level, and CMS is going to provide some more specific guidance for them on using their funds to cover SUD and opioid use issues. Also, again, more significant guidance around using Medicaid funds for telehealth in managed care contracting and school-based telehealth programs, which Medicaid programs across the country support. There's been a general idea that, we know as telehealth resource centers, since we work in all 50 states, Medicaid policies around paying for telehealth vary widely across the country. And it's a suggestion that comes up fairly frequently in our interactions with folks about, could Medicaid possibly get a little more uniform in their policies around for covering telehealth services? And of course, that's under the individual jurisdiction of every state, so there's not a whole lot that can be done there. But CMS has stepped up a bit and decided to offer some a little more specific guidance around all of those things. And then finally, as many of you might know, the Ryan-Haight Act is kind of the perennial bane of substance use disorder providers, at least those who might prescribe controlled substances. There was a safe harbor written into that law that says if you're providing telehealth services, then you don't have to worry about these restrictions. Unfortunately, what exactly is telehealth, or who's doing telehealth, or any kind of registry to record who is legitimately claiming this safe harbor of telehealth, that was written into the law but was never implemented. So this act also says that requires that DEA write out that and make a specific registry for providers who want to provide controlled substances over telemedicine, to clarify that relationship and those restrictions. And because, as we all know, when the rules aren't clear, then it becomes very, very difficult to innovate, to extend services. Nobody wants to be the one that gets caught or be the example of that DEA goes after. So this will help physicians recognize and work within the confines of that safe harbor. A couple of other things for FQHCs. This is an area of increasing interest for HRSA recently, and certainly an area that we support in the telehealth resource centers. Medicaid policies, as I said, vary a lot from state to state. And although the FQHC and RHC programs are federal in their origin and their regulation, their source of regulation, they are paid primarily by Medicaid. And so Medicaid payment policies with regard to telehealth have a significant impact on what FQHCs and RHCs can do, despite the fact that they're regulated at the federal level. So we found in looking across the states that there tend to be a range of ways that Medicaid programs support telehealth, all the way from very strictly mirroring what Medicare does, usually without a rural component, rural restriction, but that can be a very strict interpretation. There's kind of a middle road interpretation where FQHCs and RHCs are allowed to bill a pro fee in some way, whether it's only among sites or with specific site restrictions. Because in the Medicare regulations, RHCs and FQHCs are entirely conceptualized as originating sites. That's where the patient is, and that's the only way they will function in telehealth. But many RHCs and FQHCs now realize that if they want to bring in mental health services, for example, there are companies and providers that are happy to provide those services remotely, but there's confusion then about who's billing for what and how does that work out legally. And so FQHCs would like to be able to contract with providers, remote providers, and bring those providers into their four walls virtually and provide services within their four walls with their contracted provider to their patients, and then bill their PPS rate. And that's the last recommendation, or the last level there, what we're calling generous, although that's maybe not the best term. But that's an arrangement that state Medicaids will implement, where FQHCs and RHCs can bill their PPS or APM rate for patients seen within their walls, regardless of the provider's physical location. So for FQHCs and RHCs in 2019, a couple of changes. Those virtual check-ins and remote evaluation services that we talked about, they have a special code for them. RHCs and FQHCs do. They are lumped together as one service and paid a little bit differently because of the way RHCs and FQHCs are generally paid. They don't get a PPS rate for those services. Instead, they get a separate rate that they bill separately. And so because of the way they're paid, they needed their own separate code. However, interprofessional consultations are not going to be something that FQHCs and RHCs can do. Patients receiving those virtual check-in and remote evaluation services need to have been seen in the past year. So that's a way of defining an active patient. And those services are not team-based services, as I said. They need to be provided by an FQHC or RHC practitioner, a billable practitioner. Co-insurance in cases of RHCs, deductibles also apply in those cases, but CMS hasn't set any frequency limits for those services. Medicare Advantage. There are also some significant changes here that happened in 2019 or are happening in 2019, or could happen rather, I should say. CMS has made some proposed rules and are seeking comments. At least they were seeking comments last year, and these changes, are they to happen? If they happen, will happen in 2020, will take effect in 2020. And what they basically do is loosen up the restrictions around Medicare Advantage plans providing telehealth services. As we all know, Medicare Advantage is a managed care version of Medicare that has, and the requirement that has been in place all along, that these plans provide the same level of benefit as Medicare fee-for-service, standard traditional Medicare does. And what this series of changes does, or these proposed changes do, is allow Medicare Advantage plans to be a little more creative, a little more aggressive, a little more out front in leveraging telehealth and other communication technologies to provide better service. So things like broadening the definition of electronic exchange so that Medicare Advantage plans could potentially provide services that include secure messaging or store and forward live video, et cetera. And a whole range of other things that Medicare Advantage plans can consider adding into their bid. They bid for these contracts, and they can consider adding these services in as creative ways of leveraging telehealth services to provide better outcomes. The whole idea of Medicare Advantage is to let managed care organizations provide the same baseline services as Medicare, but then be a little more creative about managing those services to provide better outcomes and better service, maybe even more cost-effective service. They're incentivized to provide more cost-effective service. And so these proposed rules, potential new rules that Medicare is considering for Medicare Advantage plans, would allow them to be, would allow another level, an increased level of creativity for them to implement telecommunications technologies to provide that better level of service, that higher level of service. So I won't go into all these specific terms. I'll let Mei comment on them if she wants to, and we'll just leave it at that.
Okay, thank you, Jonathan. So right now I'm going to give you a quick update on the status of telehealth in the States as far as the Medicaid programs are concerned, and also what's going on legislatively. So for those who may have heard me speak before on state Medicaid policies, if you've been paying attention, this slide has changed slightly. Right now, we can say definitively that all 50 states in their Medicaid program reimburse for some type of live video. The last holdout was Massachusetts, and they just recently said that they will reimburse for mental and behavioral health services provided via telehealth and live video. I will caution you to read what they said carefully. There are some caveats in there. Store for remote patient monitoring, not as popular as live video, which is not a surprise, but they have been gradually inching forward. And some states are doing some very interesting things related to Medicaid, not necessarily through the legislative process, but Medicaid programs themselves have taken upon themselves to do some pretty interesting things with their telehealth policies. General trends that we are seeing, location, other types of locations where telehealth can take place. That's been kind of something that's been of the interest in, like allowing the home or allowing other sites such as schools to be a place where the patient can be located when they are receiving services. Dentistry has also gained some traction over the last year or so in allowing it to be reimbursed in Medicaid. Usually for children. So that has been a great interest, and that kind of connects with the school location sites as well. So there's a lot of interest in providing some sort of teledentistry services via school sites. Also, as Jonathan mentioned, the interest in federally qualified health centers and rural health centers is acting as a distance site. So underneath Medicare, FQHCs and RHCs cannot be distance site providers of telehealth services. They can act as originating sites, but not as distance site providers. Now that's in Medicare. Medicaid, it's a little bit freer. It's up to the Medicaid program to decide if they want to do that. And there are some states that specifically allow FQHCs and or RHCs to act as distance site providers, other states who are vague and don't really say specifically, and yet other states that prohibit it. But we're starting to see that also loosen up as well, as far as having a specific policy allowing FQHCs and RHCs to be those distance site providers. That's in the Medicaid program, not Medicare, and I want to stress that because sometimes people get confused. Medicare, FQHCs, and RHCs cannot act as a distance site provider for telehealth delivered services. And I stress telehealth delivered services because, as Jonathan went over, they are allowed to act as a distance site provider for some of those new services he talked about, such as the virtual check-in. FQHCs and RHCs are allowed to do those virtual check-in and act as that distance site provider. But if you're talking about telehealth services, they are not in the Medicare program. Private payer laws, also a big thing where telehealth policy is concerned on the state level. Some states pass laws requiring private payers to do something with telehealth. Either they'll say you need to reimburse for services regardless if they're delivered in person or via telehealth. I want to caution you because a lot of times people think that once a law passes in a state, they say, great, we've got parity for telehealth delivered services. Not always the case. You really need to examine how the law is written. Sometimes the law is written to only say you will cover, health plan will cover the services regardless if it's delivered in person or via telehealth, and that's coverage of services. There is usually not language there that says, and you will pay the same amount if you delivered it via telehealth as you would have if it was done in person. Only 3 states have that very explicit language to say you will pay the same amount. And those states are Hawaii, Delaware, and Minnesota. And also be careful of like what other language might be around in those private payer laws because they may provide room for a payer to have a restrictive telehealth reimbursement policy. So if you see something like what I have at the bottom of the slide in orange, subject to the terms and conditions of the contract, oftentimes that's not defined. Well, what do you mean subject to the terms and conditions of the contract? Do you mean if the same typical terms and conditions in my usual contract, such as, you know, the enrollee needs to pay a copay, they need to go to an in-network provider, this happens when they go out of network, etc. Or do you mean I can create new terms and conditions specifically for telehealth? So be very careful when you examine those laws because it may not provide the expansion that you think it will. So I have 2018 state legislation trends. It's because states are still introducing bills, so we don't quite have like an accurate feel of like, you know, what are the subject trends, but I would say they would probably line up pretty well with what happened in 2018. Reimbursement, not surprising, that's usually like a main focus of a lot of legislation, but also what we also are seeing are practice standards that kind of connect with prescribing as well. So those two areas, you kind of link them together in that, how can you use telehealth to prescribe is what we sometimes see. Other things that people are very interested in, or states are very interested in as far as their legislation, is licensing. Again, like always, a big issue or topic in discussion around utilization of telehealth and potential obstacles or barriers. So where licensing is concerned, usually a lot of these legislations are about joining a particular compact. Many are probably aware of the Nurses Compact and the Physicians Licensure Compact. But please be aware that there are other licensure compacts out there. There's one for physical therapists, there's one for psychologists as well. This is just a snapshot of the CCHP website. As I mentioned, we track the pending legislation as well, legislation introduced this year for the various states. That is what part of it looks like when you pull it up on our website. So I just want to have that up there for you to see what you'll be getting if you do use our website to try to access or try to look up a particular bill or bills. And just a couple of resources for you. There's the CCHP URL and the Great Plains URL, as well as the Telehealth Resource Center sort of central URL. If you wish to get in touch with a different telehealth resource center, go to that last URL and it connects to all of us. But really, you can reach out to any of us. We all work very closely together, and we can refer you to who you need to speak to, or if you want to put a question to us. I like to say, if you have a question and the TRC you put it to does not know the answer to it, they will reach out to the other 13. And I would say 99% of the time, somebody's got an answer. If they don't, usually somebody goes out and tries to find an answer for you. So that is it, and we are now moving on to our question and answer session. And I notice we've got about a couple of questions already here. So let me just go ahead and open this up. This is from Andrea. For ESRD home originating site, does the telepresenter or other healthcare professional need to be on site in the home, or can the patient be alone in the home? There was not any specification that you needed a presenter with the patient. That's actually something that Medicare has not required. They used to way back when they first introduced telehealth and saying like, well, a presenter needed to be there with the patient when telehealth was going on. But they did not require that as far as I can see from what they had in the proposal. Now, I'm gonna put a caveat on that. So what we are working from are the proposals that CMS put out, Medicare put out in the Federal Register back in October of last year, their final proposals. They do usually come out with their own fact sheets that contain a little bit more detail. And for those of you who are not aware, CMS did do a webinar after they did their final proposals talking about some of these new changes. And there were a few areas, not the ESRD one, but in some of the other things that we went over today, where they said, yeah, we understand it's a little bit fuzzy. We're putting out a clarifying FAQ. That is not out yet. So there may be additional details going forward once CMS puts out those FAQs and their fact sheets. But as far as I know right now, there's no requirement to have a telepresenter with the patient for that particular service. Will there be a new modifier for telehealth? So there are going to be modifiers. The acute stroke one, they said that they would put out an acute stroke modifier. I think they're also having modifiers for some of the FQHCs, some of those services. But I think this question might be, what happens with the old modifiers of GT, GQ, or are we supposed to use 95, what AMA sent out? As far as like overall change, I have not heard anything like that. I do understand it is confusing because Medicare does one thing and the state's Medicaid programs do another thing, and then you have private plans that do go a different route as well. But aside from hearing that they're going to have a specific modifier for FQHCs for some of those new services and one for acute stroke, I have not heard anything about a new modifier for telehealth. What is considered preventive services? From Judy Spiegel. I'm not quite sure what this question is referring to. Jonathan, do you have a thought on that?
No, I was just thinking the same thing. Preventive service.
Yeah, Judy, if you want to like re-enter your question and then, we can come back to it. If you could provide us with a little more detail, was there something specific, one of the specific services that made you ask that question, and then we'll get back to that. Would the G codes apply to behavioral health as well? Jonathan?
There are G codes that were implemented last year for behavioral health, at least in the chronic care management space. If by G codes you mean like the virtual visit and the patient and the remote evaluation of patient provided the patient provided recording, any valid diagnosis can be used to provide services. So it's not limited one way or the other. And the specific behavioral health code was already implemented last year for BHI, for FQHCs and RHCs. So I think, if I understand your question, I think the answer is yes, that you can use those codes to provide services for any valid diagnosis.
Okay. Next question. CPT code 99454 and 99457 have a rule stating do not report for monitoring less than 60 days. Do you have any clarification around this rule? So the 9954, those are those remote physiological monitoring codes. So 9954 is for each 30 days, and 99457, 20 minutes or more of clinical staff time for qualified healthcare professionals.
Additional 30 days a month. Yeah, I think the issue there is that per standard Medicare practice, they're saying, you have to be at least half a month. Those are monthly codes. And so you have to go at least over half a month to then qualify for the monthly code. For any monitoring session that goes less than 16 days, you can't bill for it. That's what they're after with that. Any further clarification I don't have, unless you do, Mei.
No, I don't on that one. So the next one is G2010. On code G2010, can you use that for INR reporting or blood sugar logs? I'm not sure what G2010 is. I don't think that was one of the things.
I don't think we talked about that one, and I'm not sure. You have to follow up with us directly.
Yeah, that one, I'm not familiar with that code offhand. Okay, so this is going back to the 99454, 99457. Does the patient have to check in all 16 days or just have the equipment in their possession?
Of course, if they're not using the equipment, it's not doing them much good, but I don't know of any requirement that they have to, how many days do they actually have to check in or make a measurement or whatever. So I think the answer is that no, they don't have to check in all 16 days. They can use it at whatever frequency they use it, but if they're using the equipment and they have the equipment, then you can bill for that. And it has to be, like you say, it's on a monthly basis.
This is on opioid SUD. Is a telepresenter or provider or clinical staff still required in the home for it to qualify as a originating site? Now, okay, one caveat there when we're talking about this, it was on the slide, but I'm not quite sure if Jonathan mentioned it. For Medicare, the telehealth SUD home as an originating site, that has not kicked in yet. That does not kick in until July 1st. So because of that, there are very few details on how CMS is going to implement that. So while legislation has passed, there's still that portion of policy where CMS will write out specifically how they intend to implement that. So that's a question mark right now. We're not quite sure what CMS is going to say, like, yes, we need to do this.
Mm-hmm.
I can say in legislation, I don't recall it prohibiting CMS requiring.
Well, and I think part of that may be residual, like Mei mentioned, that Medicare used to require telepresenters, or at least strongly recommend them, or you had to opt out. And some states, and in fact, I think some state medical boards actually, at least at one time they did, I don't know if they still do, require that for, standard of care. But Medicare no longer talks about a telepresenter as part of the standard of care for telemedicine services. So if your state does, then that may be where that's coming from, but it's not a standard requirement across the board for telehealth anymore.
Yeah, so that's more of a stay tuned until we get further details from CMS on how they're going to implement that. But most likely not. I think probably, at least where Congress is concerned, when they passed that piece of legislation, they were thinking of getting those mental health, behavioral health services for SUD treatment, allowing people to access that from the home. So if that's sort of what they were thinking of, and that may be how CMS defines it too when they come out with their parameters. I would say it would be unlikely that you would need a telepresenter there if they limit it that way. Because,
yeah, I'd be surprised. I'd be surprised if they did that.
Because I think in the legislation they didn't specify saying like, oh, it needed to be all these broad services. They just kind of left it open. So there's that. It's a stay tuned. We'll see what CMS comes out with. For RPM code 99454, which covers device supply, is that a one-time only charge? Sorry. If not, is there a limit to number of months?
I think that code, there are 3 codes in that remote patient monitoring. The first one is spending the time educating the patient how to use it and setting it up. The second one is a month of using it and supplying it or maintaining it. I think that's a monthly sort of equipment maintenance fee, and there's no limit in how many months you can do that. And that last one has to do with interacting with the patient around the coding or around the recorded information. So no, I don't think there's a limitation on how many months you can maintain that equipment.
Now I'm looking at the definition, and there's nothing specific there that I'm seeing right now. The definition of the code itself.
The initial code, the initial code, obviously training the patient to use the device, that's a one-time code, or at least wouldn't happen very often until they get a new device or a different device.
All right. Okay, so there's a couple of questions from Nydia, and I apologize if I'm pronouncing your name wrong. So I'm going to take all 3 of those. Sorry, I got confused with the rule for FQHC and RHC of the provider site. Is it mandatory that the doctor needs to be at the clinic site or not? Live video covered by 50 states, but doctor can be at home. Does that apply for California too? So I can take the last 2 portions of our questions. So I'll do that first, and then Jonathan, you may want to answer the first part. So live video covered by 50 states, doesn't matter that the doctor is at home. For the most part, Medicaid programs in the 50 states don't really specify the location of the distance site provider. Now, there may be other rules involved not related to telehealth where they say the distance site provider, or where they say a physician needs to be when providing services in order to be reimbursed by Medicaid. But a lot of states don't really have that specificity when it comes to telehealth. But I'm warning you, there may be other rules in their Medicaid program where there may be specificity. And I'll give you an example. It's not necessarily a home example, but in California, there's a rule where they're saying a Medicaid provider providing services to a Medicaid enrollee needs to be located within the state of California in order to get reimbursed. That's not in the telehealth section. It's in a different section of like the Medicaid rules in California. So that's why I'm saying like there may be other areas where there could be that limitation on the distance site provider's location. Now you asked a question about California, and I just answered that for you. But one thing I want to say about California is that California currently is redoing their Medicaid policies regarding telehealth. And I've seen draft proposals on it. It's very exciting. That was one of the states where I said some states are doing some exciting things. They're not finalized yet. They said sometime in the spring. I kind of, from what they said, thought maybe April this year, but you know, sometimes they're a little optimistic on when they may meet a certain deadline, but they are coming, and there are a lot of good things in there too. A lot of other things where it's like, well, you could have gone a little further, but a lot of good things as well. So, Jonathan, you want to take the first part of the question?
Yeah, and I'll. So this will vary from state to state, but in states that allow FQHCs to contract with remote providers. As Mei mentioned, the location of the remote provider is more or less irrelevant. They are practicing virtually within the FQHC or RHC. Now, again, not all states allow that form of practice, but in those that do, and California is one of them, the actual physical location of the provider at the time of service is irrelevant, as long as it's, secure and professional and reasonable sorts of considerations apply there.
We suggest you not do like a visit while in Starbucks using their Wi-Fi.
Yeah, right. Or McDonald's, or when there's a family member in the room.
Yeah, just don't do that.
Dog on your lap.
Yeah. Is there
okay.
a certificate? Is the question, are there like
for this webcast or webinar? No, we don't have a certificate.
No. For documentation to show attendance, no, we don't have that.
You can email Ray and he can send you an email saying you came.
Thank you for thinking that this is great enough to like qualify for
And I just threw Ray under the bus. So.
Yeah, but we don't have that set up, sorry. For the CPT code 99451 and 99452 for live interactions only between providers, or can they be used for store and forward situations? Trying to remember what 99415 and 452. Are those the earlier ones? I'm not sure what those codes are.
Oh, I think that's okay. So that's the interprofessional consultation codes, and I think that's the second group of codes at the bottom of the page. And those are they're not. Store and forward is usually refers to something a little bit different, but I think the intent of those codes is to allow the consulting provider to basically review existing material. I would assume it usually means, an electronic chart. Now that electronic chart might include pictures or diagrams or something that you would traditionally use in store and forward, but the focus of those codes is that it's an interprofessional consultation. And store and forward usually implies a patient-physician interaction. So that's the difference there. Can it be used for store and forward? Well, yeah, kind of, but it's a consultation between doctors. And usually when we use the term store and forward, we mean a patient is providing some information to a doctor.
But if the person, Chris, if you're asking this question, you're saying, can I do it like with a phone call and get paid for it, or does it always have to be, I send like everything through a secure email system? You can do either. So it can
be asynchronous and otherwise.
Yeah, you can do it in an asynchronous way, or you can do it in like a real-time way. So it's allowed, because they do say underneath the definition, it could be telephone, internet, electronic health records. So they allow for sort of both type of, timing-wise. Okay. Is there any pending legislation to lift the originating site requirement across the board and allow for all services? There is always pending legislation. The question is, will it ever get to a committee to where it's a long process? So there is a lot of interest. The thing is that there's not that there's not interest in Congress, and there's actually bipartisan interest. It's just, I think, other factors going on in Washington, D.C. that has them distracted doing other things. And we'll just leave it at that.
CBO tends to score it fairly expensive too, and that's always a big concern, even though it may not be. And telehealth has never turned out to be very expensive for Medicare.
Do you know how many states allow schools as originating sites? Oh, it's like roughly, not offhand, I have it somewhere, but not off the top of my head. It's like roughly between 15 and 20 Medicaid programs explicitly allow schools to be originating sites. And I say that explicitly because there are some states in their Medicaid program where they don't explicitly say, they don't have like a handy list that says all these sites are eligible originating sites, but they will allow it. It's just, I can't count that because I don't have like an explicit reference that I can point to. But I know that they are allowing it because there are programs in those states that are getting reimbursed for it by Medicaid. So it's 15 and 20 may have been high. But it's around that number there. But it's increasing, I think, every year. I've gotten like calls from around the country where people have expressed like an interest in like expanding it. Is Medicare reimbursing urging site fees in all states? So regardless of what state you're in, if you are a Medicaid enrollee and you are in Medicare enrollee, and you are in a location where you can receive telehealth services, and your originating site is one of those eligible services. It's not like an acute stroke service that you're receiving in an urban hospital, because underneath like the new policy, they are like a new type of site, and that's allowable where telehealth can take place. They don't get an originating site fee. You're allowed a facility fee. If you're like one of those originals, it's not the state law there. If you're a Medicare enrollee, you check all the other requirements of like receiving telehealth services. That location that you are in should be eligible for that originating site fee. If you're talking about Medicaid, depends on the Medicaid program, and not all Medicaid programs provide a facility fee. Is it accurate that telehealth is only reimbursed at the 100% physician rate every third visit for inpatients, and otherwise at 80%? Is this the same rule for the admitting visit? I'm going to assume you're talking about Medicare, because it may vary for Medicaid programs, so I'm assuming the question is related to Medicare. Not heard Medicare saying that they would only pay for 80% of provided via telehealth. My understanding for Medicare, and actually for a lot of Medicaid programs, they pay the same.
Well, this may refer to the 80% or the 20% co-insurance for Medicare. I'm not familiar with this one.
Yeah.
And so, for inpatients is different. There are limitations on how many visits you can do inpatient, but the reimbursement doesn't change.
For Medicare ACOs, do we know if telehealth visits count towards a patient's RAS score? If so, is there a link where this information is shared?
I have not heard specifically that, but a telehealth visit is a visit. So I don't know what the justification would be to not count them. It's at least other than a small subset of things that can be paid. If Medicare is paying for a visit, it's a visit, whether it's a telemedicine visit or not. A lot of times people confuse other types of services like this virtual visit or virtual check-in or remote patient monitoring and call that all telehealth. And I don't know exactly how all that is scored. But if it's a live synchronous encounter that is billable under Medicare's telemedicine rules, then it's a visit and it has the same CPT code as an in-person visit.
Okay, from Elaine Wilson, thank you, most useful. Yay! So Elaine, remember to fill out our form afterwards, or read that form. Have there been new developments specific to telepsychiatry?
Not aware of any.
No.
I mean, psychiatry visits are medical visits, so any of the things that we've talked about here, the collaborative care for telehealth or for psychiatry codes, of course, went into effect last year, and those continue.
Yeah, it's usually one of the more popular. I call it the gateway specialty for folks who are leery of telehealth, saying, how can you do that? You can't touch the patient. And so it's like, well, because psychiatry, you probably shouldn't be touching the patient in that session. So, okay, can you please list the 13 states that allow Medicaid reimbursement for telehealth services provided to the home? If you get in touch with us afterwards, we'll provide you with that list. Sorry, the thing keeps jumping up and down, so I'm like trying to figure out which is the next question. Let's see. Are there any restrictions in the Medicaid states on what type of video devices can be used? Not specifically, for the most part. The language, as far as like the type of equipment you're supposed to be using, it's really left up to the provider to decide. One thing I will say though, it's not necessarily listed out in the Medicaid policies, but check with the state licensing boards, because sometimes they give out guidance to their licensees saying like, and this is how you should be doing telehealth. For the most part, they're not onerous. They're saying like, do it same sort of professional type of service that you would give if you did it in person, but sometimes they do have like certain other qualifications or caveats in there. So double check those licensing boards. We have a family, oh, Jonathan, go ahead.
I have to drop off, May.
Okay.
Sorry, because I've got
All
a
right,
hard
I will
stop
try
here.
to answer as much of these questions as I can. So Jonathan, thank you so much. You know, folks, if you want to reach out to Jonathan, I gave you his website URL. You can get him through there. Okay, thank you, Jonathan.
Thank you, bye.
We have a family clinic in a rural area and county. We would like to offer telehealth services to our local clinic surgeons. We will have a claim for the originating site and a claim for the distant site. So are you trying, from my understanding of this, so rule of thumb, you're not supposed to claim, put a claim in as originating site provider and a distant site provider. That may be considered double dipping. So I'm not quite sure I understand your scenario here. To our local clinic surgeons, are those local clinic surgeons connected specifically with your clinic? Because my understanding would be you are where the patient's located, so you would be the originating site and you could submit for a facility fee if the payer that you are submitting it to offers that facility fee. But the distant site provider would be the one charging for their services. So I'm not quite sure what scenario you're thinking of, but that's sort of more the typical scenario that they would have in a telehealth program.
Hi, May. This is Ray. I think the anonymous attendee might have followed up. They said same tax ID, 2 different doctors. I'm not sure if that gives you any more context.
Same tax ID, 2 different doctors. So it is like the same. They're associated. They're the same entity. Then I would doubt you would be able to get that from any payer, because it does look like you're charging 2 things there. Usually there is a separation between the originating site and the distant site provider there. So, okay, does the telehealth need to be CERHT? Can pilots be reimbursed? Can nurses overseeing patients be considered a provider? What is considered preventive services? Is this reimbursable? Again, it depends on what you're talking about is the payer. So for pilots, it depends on how the pilot is set up. I don't know if like the pilot is offering you some compensation for providing those services, or the pilot that's set up and you're expected to reach out to a particular payer. All of that is going to vary. It's going to vary like what payer you're using. Are you using Medicare? Are you using Medicaid? And they vary on like, you know, what providers that they reimburse and what services they will reimburse, and also the location as well. So I'll need to understand more details about that. Okay, so I think the preventive services question for Judy was in reference to Jonathan's content, remote evaluation. Still a little G0513. So, you know what, Judy, why don't you just email Ray and have him and put him in contact with me and Jonathan? I think this might require more of a discussion for you, because I'm still a little bit unclear on exactly what you're trying to get to. So we'll try to answer your question offline. Judy Amore, I know you. So for a brief virtual check-in, does it matter who initiates the contact? That is, can a provider initiate the contact in which the diagnosed depressed patient to see how the patient is doing? You know, that one was a little bit vague in the live video check-in. The remote one, it is specifically that the patient initiates that, but the virtual check-in, that is a little bit vague on who can do that. Hopefully when Medicare comes out with those FQHCs, it's made a little bit clear, but when they did the final proposal, when they published that was like a little bit fuzzy. We couldn't quite figure that out. They were very clear about the remote patient, the storm before asynchronous version of that. They said that needed to be patient initiated. Rural areas of California doctors need to drive long distances to work at any of the FQHCs and RHC. If I want to work for one of them, offering telehealth service for my urgent care visa does not make sense, and the provider needs to be at their site. I'm not quite sure what the question is there, to be honest. G2010 was the patient-generated consult. Sending in a photo of a rash was the example given. Again, I'm not quite sure what the question is there. If telehealth is used to verify home care services and monitor weight, blood pressure, sorry, the thing keeps jumping here. I'm losing my place. media is this reimbursable? If telehealth is used to verify home care services, monitor weight, blood pressure monitoring, and care, and a nurse oversees the media, is this reimbursable? I think you are thinking of some of those remote physiological codes. So I think the nurse was a qualified health professional. This was one of those areas where CMS said, yeah, we understand that was like a little bit fuzzy. So we're not quite sure, you know. This was a question that came up when the CMS call where people had asked, like, what do you mean by other qualified healthcare professional? I think the nurse would qualify because they're clinical staff. But CMS did admit that was a little fuzzy, and they would come out with more explicit explanation on like the definition of what a qualified healthcare staff would be. But I think a nurse probably would fit into that if you're talking about those remote physiological codes. If you're using these if these are the services that you're talking about, then it would be reimbursable if the nurse is doing that, if you fit into one of those definitions for those three codes. For clarification, the originating site for Medicare coverage of telehealth service guidelines has not changed yet. Not quite clear on what you're asking. So aside from the Medicare Advantage stuff that we talked about and those opioid SUD items that we talked about, those have not kicked in yet, but all the other changes have kicked in. So that does mean, yes, the originating site changes for end-stage renal disease and for acute stroke have changed. Those are now in effect. Those went into effect the first of the year. Is pre-authorization required for telehealth? No, it is not. And I'm assuming you're talking about Medicare. So we are writing statewide telehealth policy in Florida, looking for best practices and policy template. Can you help? Contact me offline. So because like I said, everybody does it differently, and a lot of the reason they do it differently is because they have different needs in different states. So what may work, say, in California may not work in Florida just because of like different needs and different conditions that are out there. Okay, so we're back to 2012. Does it apply for MDs only, or can social workers use that code as well? So G2102, I am so sorry. I don't really know codes off the top of my head, so I always have to pause and think like, which one is that? I can't remember off the top of my head what the 2012 code is. I'm like scrolling through our presentation really quickly to do that. I don't think we went over the 2012 code. If it is a telehealth code, if I'm remembering correctly, I don't think social workers are eligible providers provided via telehealth, but you might want to just contact us offline after I've had a chance to check that, because I need to get off soon, but I want to try to get through as many questions as possible. We want to do telehealth from one location and reaching out to our clinics in rural or remote parts of the state. Some of the patients coming in will be in the state, but a clinic on the border might have patients from another state. Do providers have to be licensed in those states? Typically, yes. There are a couple of states that do have some type of reciprocity or allow exceptions within like a certain distance from the border. There are very few exceptions though. For the most part, if you are providing services in another state to citizens of those states or patients located in that state, you will also need to be licensed in that state. But there are like a couple of exceptions to that. You can look at our 50 state on CCHP's website. We do like make notations of those exceptions, but they're really, really rare. So I would say there's a good chance that the states that you're thinking of where you're located most likely will require that license. What impact is there regarding credentialing for Medicare? If credentialed for Medicare, is this covered for all services for anyone in the country, i.e. remote monitoring? So for credentialing, I'm not quite sure what you're referring to on the credentialing, because there's a couple of ways of looking at that. But basically, we're back to kind of some of the licensing questions as well. So if you are providing services via telehealth and you are providing them to a Medicare enrollee, you will need to be licensed in the state where that enrollee is located, because most likely what you might be doing is working with a clinic or a hospital That's what a lot of situations are, especially when you're talking about telehealth, because that's where a patient needs to be located. And that originating site where that patient is located as a clinic or a hospital will have, most likely credential and privilege you in order to provide those services. And underneath the regulations regarding Medicare and conditions of practices, though, for that credentialing, you need to be licensed in that patient's state there. So even though you may be you may be like a Medicare approved provider or something, most likely when you're reaching out to these patients via telehealth, you're typically doing it in where they're in a location where that entity needs to credential you to provide those services within their walls. And like in order for them to be able to do that, they would most likely require you to be licensed in their state too. So I'm not quite sure if that answered your question or not, but that's kind of like, you know, the basic scenario there for that. It's like, you know, you're credentialed in your home state, but if you're providing services in other states too, there may be some extra steps you need to go through. How do you define home? If someone lives in assisted living, is that considered a home or SNF? It depends. So it depends again. You haven't quite said specifically what you're looking at. What payer you're looking at, the policy varies for Medicare and Medicaid and private payers. They may have different definitions of home. Sometimes they're very specific. A lot of times they just say the resident of the patient. So it could be a SNF. Underneath Medicare, SNFs are an eligible originating site for telehealth. So they specifically say that. So the home, most likely, depending on the payer, would include like other assisted living facilities where the patient is located. Adult Medicaid enrollees in California have benefits for medical nutrition therapy for diabetes, but RDNs are unable to enroll as Medi-Cal providers. So the only way the patient can receive the services is when the physician does the billing. Are there any exceptions with regard to telehealth where the RDN could provide the service to the Medi-Cal enrollees via telehealth and not require a physician to bill? Not at this time. So, and if I understand everything clearly on that, in that they can't be a Medi-Cal enrolled providers, even with those changes coming in from California, unless they've changed them from like what I've seen from the draft, which is possible. Even with those changes that I said were coming in California Medicaid program, that is unlikely to change as well once those changes are implemented. Do you see telehealth to really grow due to these changes? Yeah, I do. I think there's going to be growth in telehealth year by year because it is becoming more accessible, more popular, more well-known. People are feeling more comfortable with it, and some of these policy changes are going to assist in its greater utilization. Are we going to see a sudden explosion because of these changes? Probably not, because it takes time for people to get things implemented and get comfortable and get started. But it is, I think there will be an increase. For CPT code 99454, does this mean a health professional must receive program alerts at least once a month and they can get reimbursed monthly? I'm not quite sure what you mean by program alerts, and I think for 99454, it's more not about program alerts, but that they've actually provided some type of service in order to get reimbursed. Yes, Medicare found the guideline on the resource site for inpatient. Guideline is from the 2018, says Medicare Learning Network, says subsequent hospital services with limitation will telehealth every 3 days. Okay, I'm not sure if that's a specific question. Is there any documentation I can get from California board stating I can provide contracting telehealth services to FQHCs RHCs? I haven't been able to find anything I can show them. I mean, I am at home. Assuming you're talking about the California Medical Board, I highly doubt it. I don't think that they have any type of like certificate or any type of letter that they can provide. I assume that's what that question is. I'm not quite clear on that. Can you elaborate on the augmentation for telestroke reimbursement? Is it site location or service? So for acute stroke, the new rule is if you are providing acute stroke services via telehealth, that geographical restriction no longer applies to you. So yes, you can provide acute stroke services via telehealth in an urban hospital, and you will get reimbursed for that. Prior to 2019, that was only limited to rural areas or, you know, non-MSA areas. But now in 2019 and going forward, they're saying, yes, these urban areas, these other locations geographically that weren't eligible, you can now provide acute stroke services via telehealth and you can get reimbursed. However, if you are one of those new areas that became eligible in 2019, you do not get the facility fee. So that's what that means. It's a little tricky there in understanding that, because it does mean some places get the facility fee because there are those sites who qualified in those old requirements and that they were in a rural area and they provided acute stroke, they get a facility fee. But now you're a site that someone becomes eligible, you do not get the facility fee. So it is a little confusing and trying to like sort all that out. Can a licensed practical nurse complete the remote patient monitoring enrollment process and get the patient consent to participate in this program? I'll need more information on that. I'm not quite sure what you mean by, are you talking about Medicare or are you talking about like a Medicaid program? I'm not quite sure exactly where you're landing on. And I apologize for that because we did go over both. So again, it depends on who you're referring to. Assuming maybe Medicare, I don't think it went into that great of detail, the proposal. That might be one of those FAQ things that CMS needs to clarify as well, if you're talking about Medicare, and if I'm thinking of your question correctly. For the opioid telehealth, can the visit be done in the home? Are they able to prescribe, I think, suggest Suboxone without having to go through a site? Okay, so for, again, the opioid stuff, it has not kicked in for Medicare until July 1st, and right now we only have like what was said in legislation. So again, there could be more details coming out where there is limitation, but I want to say though, so when you're prescribing Suboxone, it's a controlled substance, and as Jonathan talked about, there are limitations in how you can do that using telehealth, because otherwise you would need an in-person visit with the patient in order to do that before you can prescribe. So there are 7 exceptions underneath the Ryan-Hay Act that allows you to use telehealth to prescribe without an in-person visit. Those exceptions are very narrow. It's such, some of them are like, if it's an emergency or natural disaster, or if the patient's located in the DEA registered facility. So most likely, you know, if you're talking about the patient just being at home, that most likely is not going to qualify. Jonathan did talk about the registry. So the registry is one of those 7 exceptions, and the DEA is now supposed to like have final regulations on what that registry is going to look like. Theoretically, it will, you know, open things up, because once a telehealth provider gets on that registry, they should be okay to go, and they don't need to go into one of those 6 other exceptions that are very narrow. Problem with the registry is Congress told DEA, you need to do this and like create this registry in 2019. It didn't tell the DEA how to do that. So it could, theoretically, the DEA can come up with a very onerous process where providers can look at it and say, it's not worth my effort to get on that registry. So it's a wait and see in like whether the registry would really be sort of more of an opening up for us. So just be cautious there on like the whole prescribing thing. Now, if you're talking about administration of Suboxone, that's something different. So there is not like kind of that narrow restriction that you have in the Ryan-Hay Act on prescribing. If you're talking on administration and like monitoring something, that's a whole different story. But again, I don't quite know exactly how CMS is going to describe and regulate and define what those services in the home are going to be like when you're talking about substance use disorder. All we have right now is the legislation saying like, you do it, CMS, but they get to fill in all the details. So that's sort of a wait and see. And the last question, if the originating site is a provider-based clinic and originating site, will the claim form be a facility claim since it's an outpatient department? Report the 23114. I'm sorry, I'm not quite sure I understand the question. If the originating site is a provider-based clinic and originating site, will the claim form be a facility claim since it's outpatient? Yeah, I apologize. I don't know if I really understand what the question is. If you want to submit like a more clarifying question to Ray, we'll try to answer it after this webinar. But right now, I'm not quite sure I understand what you're asking. And that is the last of our questions. So I only have one last thing to do with everyone, and that is, I hope you can see this. Here, let's see. And that is our information about our next webinar through the consortium. And that is on March 21st. Please note that the time is different. We typically have our webinars at 11 a.m. Pacific time. The one for next month is actually at 10 a.m. Pacific. And it's on creative telehealth training in an academic setting. And as I mentioned earlier, this is a survey. If you could please take a survey letting us know what you thought of this webinar, we would really appreciate it. And I just wanted to say thank you all for being here. I'm sorry we couldn't give you more detailed answers to some of your questions. If you have follow-up questions, please send them in to us and we'll try to get to them over the next couple of days. But thank you so much, and that is the end of our webinar.